Hey, AJ here. So we've had some requests from folks on WhatsApp and on YouTube to create more content about programming devices and navigating programmers. I think it's pretty popular because it's something that you can really only do from experience or through observation, and sometimes observations, especially in resource constrained areas, can be kind of tough. So today, by popular demand, we're going to be going through PSA testing on an Avid programmer. So to start with, I'm going just to play a video and do a talk through of what's going on. And then I'll go over some example slides. And then finally, I'm just going to play the entire um, procedure from start to finish without me talking at all. So then that way you can review it in your own time. And yeah, hopefully you gather some valuable insight from it. So without further ado, all right, so we have a Merlin 1 programmer. The lead is already screwed into the tissue of the heart. It is now sticking outside of the pocket, and the physician took the PSA cables, took the black to the tip, red to the ring, and then that cable is running here to the PSA and plugged into the RV or middle port of the PSA, which is why we're seeing on the EKG or the surface this evoked response. And then in the middle channel here, you have your EKG on the surface, you have your marker channel here for VS, and this bottom channel is the RV. You have this initial noise when you hooked it up and it's being wiped over here. Our friend is going to vocalize as we go through it, so I'll let him lead the
Go for it.
way. So the first thing he does here is click this little button to then bring up the extremely zoomed in or gained up view of the signal so we can take a look at the injury current. Clicks on the injury current, and then we see it
So
here
great injury
visualized.
current.
He calls out the injury current looks great. If you saw it, you have this widened QRS here. But you can still see the remnants of it. It's about 50% of the signal. Once again, the injury current height is not necessarily the biggest issue. It's the injury current width. So if you're thinking about it like a STEMI on an EKG, you're looking at that initial tissue damage. A wide injury current indicates that you've done damage to the localized tissue, which I will talk about in later slides. Calls out the injury current.
RA
Moving along.
4.8, 4.5. I'm
Now he's calling out the sensing. Once again, vocalizing injury current. Now we're saying how the sensing looks to the physician. Sensing values we'll talk about later.
going on.
Comes on pacing here.
Impedance 6.
You can see an immediate capture on the EKG, and he starts calling out his impedance values. Impedance values is another important one to look at, which we will discuss later. But you see here, he's vocalizing everything that he's seeing as he goes.
270 great impedance. I'm running the test. Can we check
He's going
for
to run the
10
test
volts?
and goes straight
Any
to 10 volts
diaphragmatic.
here. When you hit this little 10 volt button here, it kicks it up to 10 volts at 1.5 milliseconds. That increases the amplitude, trying the best to ensure diaphragmatic stimulation if it's possible, right? You want to see if it's possible with this lead placement to stimulate the phrenic nerve, PNS, right? If you have that, that could cause a hiccuping sensation, which is not ideal for patients. Better to locate it now while you're placing the lead. Physician
Nothing.
feels nothing in the
At
diaphragm.
5,
Moving along.
I'm capturing. At
Our
4,
friend goes to
I'm
his capture test,
capturing.
goes to 5, comes down
3
here,
volts,
and he's
capturing.
vocalizing throughout this whole
2
thing
volts,
so the physician knows what's going
capturing.
on. There's nothing worse than
1.
silence.
I lost at 1, back to
He
2.
loses at 1,
I'm
increases the
coming
output.
down slowly at 1.8.
So once you've established where loss is, you want to go up to a value above that and then start coming down until you lose, right? So he comes down from here.
1.8, 1.7, 1.6, 1.5, 1.4, 1.3, capturing still, 1.2, 1.1, 1, still capturing, 0.9, 0.8, 0. I lost at 0.8, so I'm saving at 1.
Perfect.
Okay?
Go for it.
All right, so what are our big takeaways here, right? So he initially started and saw his injury current. Injury current looks good, nice, wide, good amplitude, but once again, we're looking at width. Next, he looked at his impedance. What is the impedance? Is it within an acceptable value? Greater than 2000, 3000 impedance could indicate a couple things. It could indicate perf. It could also indicate that you've just hooked up your PSA cables a little bit incorrectly, so they're not properly seated on the ring and tip electrodes at the back of the lead. So if you have an out of range impedance, check your cables first, right? If your impedance is too low, same thing. Maybe the covering, those little rubber coverings, has backed off, and now those clips are touching, or they're touching at the tip. That will also cause a short circuit, which will lower impedance. Check that first. Injury current. If the injury current is negative, that could indicate perforation. It could also indicate that maybe you switched your cables, right? Maybe the red is the tip, black is the ring. If you see that, sometimes physicians will do it to mess with you too. Make sure to call it out and see what's going on. Another thing to do when you look at impedance is you can go ahead and take the red off of the ring and hook it to the skin or a metal instrument in the skin. This effectively goes unipolar. If your unipolar impedance is higher than your bipolar impedance, could indicate perforation, because if you think about it, you've now protruded through the tissue, which means you're kind of an air, right? It could also, you know, um, not be a perf. It's one of those little things in your toolkit to look for. Same thing with capture. Is your capture threshold worse with unipolar than bipolar? Typically, you expect unipolar capture thresholds to be better. So just things to keep in mind there. Next, he went to his capture threshold, and he starts high. He comes down. I usually go 5 to 2 because I'm usually confident it's below 2, but not always, as we'll see later on, right? 5, had it at 3, 4, 2, went down to 1. We lost it at 1. So there we go back up to 2, and then we come down by decimals then until you lose capture, and then you hit save threshold. So we hit save threshold on that screen, and that immediately kicks it up to 5 volts to ensure that you have capture, and that means that, to me, everything indicates it's a good lead placement, right? The impedance is good, injury current is good, sensing is great, everything looks fantastic. Nothing to indicate we should move the lead. But I think this is a textbook way of walking through the PSA. And we'll go through it one more time here at the end.
Go for it.
So now we're going to look at some cases that are a little bit more complicated, or at least worth studying. All right, so this was actually from a previous presentation that I've done, and I will cite it um, in the bottom of this video. And I highly recommend you watch it because it's a deeper dive, and I'm not going to cover all of the concepts from that here. I'm just going to cover some high-level things. But I really wanted to show this to visualize what we talked about as far as injury current. So this was some cases that we did in Milo, Haiti, back in November 2023. We're doing a ventricular capture test. You can see that the injury current is about 50%, so about 5 millivolts of injury current, nice and wide here. It lines up with the QRS complexes, and we are sensing here, right? You're sensed injury currents. You don't mess around with the pacing one. It's not going to do you any good. Another thing is, like, obviously we're looking at width, we're looking at positivity, and everything indicates a strong injury for me. Let's look at the atrial injury current. Same thing. We know we're in the atrium, not because these atrial markers, because once again, you can accidentally plug it in the wrong port. That'll say VS here. We're looking at our EKG. It lines up with the P waves. This one lines up with the QRS, but that's just because the P wave is buried in the QRS here. This T wave is tall, same thing. That's a little bit of fusion here on the EKG, which is making it look like it's a tall T wave, but there's a P wave buried in there. We see our rhythmic P waves. We see our injury is almost 100% of our injury current. It's still about the same amplitude as the injury from the previous one, which is why I'm always saying don't go off the height of the injury, because this looks like a better injury. Technically, it's lower. What we're looking off is the width. Everything here, as long as everything else looks good with your sensing, with your capture, with your impedance, I'd say we're in a good spot to place these leads. But what about What about in cases where you don't have good numbers? What about in cases where you don't have good threshold? So here's an interesting example. We were replacing a lead, and we went to pace in the atrium, and we had a very high threshold, right? So we pace, we see an evoked response here. It's kind of flat, plateaued, but we know that it captures because it immediately conducts down, right? Paces, conducts down. Could it be circumstantial conduction? Yeah, I mean, it could just be that but in this case, we're pretty sure because we decrement down, we pace, we don't have the same evoked response. There's no conduction. That indicates before that we were driving the rate, right? So I'm now thinking, okay, I was driving it before. Now I'm not driving the rate. We have the intrinsic breakthrough, right? We're no longer pacing. It's been this whole time without any activity in the atrium. So the atrium has no longer suppressed. Doesn't always happen. Sometimes it gets suppressed for periods of time. It has its intrinsic breakthrough and then the conduction associated with this. One thing to note, the EKG of the atrial looks very different from the intrinsic than the pacing. Why? Because we're pacing from a different part of the tissue, right? We're pacing not from the sinus node, but from a different aspect. It just causes a different depolarization, which causes it to look different on the EKG. But things to recognize here. I'm using all my context clues. We have intrinsic breakthrough, we have conduction, and it all corresponds to me decrementing my output pretty cut and dry. The worst cases are when you have an atrium with no intrinsic conduction down to the ventricle and with no intrinsic sinus activity or backup. So you're kind of dealing with a dead atrium. It can be a little misleading. That's when your surface EKG is your friend. And that's why I always say, if you can hook a surface EKG up at implant, it will possibly save a life. So always have a surface, and then if you're testing outside, with a device, always have a unipolar. But you don't have the unipolar option here. Have a surface. They're already in a setting. They're already, sedated. Just put some patches on. It'll make life easier. All right, so we do our threshold test, 2.7 volts. Okay, that's not great. And your first inclination is to say, okay, I don't like this location, but remember, especially in the atrium, your thresholds can be very high initially, but come down quite a bit. And that's because a lot of leads have, modern leads have steroid elution, which means that the steroids take effect and actually will bring the threshold down considerably. And you don't have that chronic threshold rise that you used to have back in the day. So if we see an initial high threshold, my advice to you is give it some time, ask the physician to maybe tie down another lead or work on another access or do something else, work on the pocket while you give it time to settle in. Why? If you move a lead, you run the risk of getting tissue stuck in the helix, is going to complicate things. You run the risk of increasing perf risk, of, you know, making the case run even longer, which increases their infection risk. There's all these different, non-ideal situations that can come from moving a lead and just being too antsy instead of just giving it time. So we give it 5 minutes. We check the threshold again, decrement down, and then you can see here the evoked response changes. There's nothing on the EKG. The evoked response on the EGM changes. This indicates that we've lost capture. There's no conduction down. The intrinsic breaks through here. Okay, so that means we lost capture at 2.1. Threshold is now 2.2. Our threshold has come down zero point 0.6. That's great. Still not where I want it, but it's good. So what do we do next? Give it another 5 minutes. All right. Check it again 5 minutes later. So it's only been 10 minutes since we implanted the lead. Yeah, 10 minutes is a long time, but hopefully you've learned how to make conversation by now. So we decrement down zero point 0.9, zero point 0.8, zero point 0.7. We get to here, lose capture. Obviously, right around here, there's no conduction, there's no evoked response. Morphologically, now a little more narrow than the other one. Intrinsic breakthrough, new threshold is zero point 0.7, or sorry, is zero point 0.8. Loss of capture is zero point 0.7, well within acceptable range. I think when we left that day, the threshold ended up being 0.75 or something like that. I'll take that any day. Love it. Just give yourself time. Things to keep in mind. Your threshold can be artificially lowered due to the Wendinsky effect. That usually only has about zero point 0.1 to zero point 0.2 volts of difference here, but just to describe the Wendinsky effect, because you'll come across it, artificially lowered thresholds due to consistent capture of the tissue. So if I'm capturing it all the time at 1 volt and I drop it down to zero point 0.7, I lose. Now all of a sudden you could see a threshold jump to, instead of zero point 0.8, it could be at zero point 0.9, or 1 volts is your new capture threshold. So you wouldn't capture at 0.8, you wouldn't capture at zero point 0.9, but you are capturing at 1 volt. That suppression from the pacing has lowered the capture threshold artificially. So your threshold is actually probably in that case around zero point 0.9, but because of the Wendinsky effect, it has lowered it down to zero point 0.7. So as soon as you lose capture, it may take more energy to capture again. Why does that matter? That's why you set nice voltage margins, because say you lose capture in the field, positional effects, many other things that can affect capture thresholds, medications. Now all of a sudden you're not capturing, and now the threshold is higher than you had set it. Always give yourself a 2-to-1 safety margin, or use a beat to beat, or some sort of capture assurance to make sure that you have a good margin. If you're only setting a zero point 0.5 voltage margin on a dependent patient, you are doing that patient a disservice. So always get yourself a nice safety margin. That's all I really had to cover there. And then we get to this ventricular capture test. This is just with the device. I just want to throw this in just so you can see how it looks with the device itself. 0 0.7, 0 0.5, 0.25 ventricular capture there as well. Same thing. It looks very similar on the device as with the PSA. You don't quite have as much control with how much you can reduce the voltage. So you can't go down by like 0.1. You're stuck with 0 0.7, 0.5, 0.25. Same thing though, right? All right. All right, so as promised, I will try to keep my commentary to a minimum, but I will highlight the important parts here. And we'll go through it one last
Go
time.
for it.
So
Demonstrates the
great
injury
injury
current.
current. RA 4.8,
Also
4.5. I'm going
calls out
on.
the R waves. Comes on pacing by hitting the on button here.
Impedance 670, great impedance.
It's now
I'm
visualized,
running
hits
the
the run
test. Can we
test.
check for 10 volts? Any
Diaphragmatic
diaphragmatic
stim.
pacing? Nothing.
Nope.
At 5, I'm capturing. At 4, I'm
Presses
capturing.
these buttons to reduce output.
At 3 volts, capturing. 2 volts, capturing. 1. I lost at 1, back to 2. I'm coming down slowly at 1.8,
These allow you to come down by decimal points.
1.8, um, 1.7, 1.6, 1.5, 1.4, 1.3, capturing still, 1.2, 1.1, 1, still capturing, 0.9, 0.8, 0. I lost at 0.8, so I'm saving at 1.
Perfect.
Okay?
One thing I'd like to note is when you lose capture, you can manually increase them by either hitting the plus button or hitting one of these buttons, or if you just hit save threshold, it will save the loss of capture. Say if you say you lose capture at zero point 0.7, it saves the threshold as zero point 0.8, and it immediately goes to 5 volts. It's a good way to ensure that you have capture or right away, ideally, as long as the threshold is above 5 volt. If it's below 5 volt, if it's above 5 volts, then there's other things we got to talk about. There we go.
Go for it. Go for it.
So great injury current. RA 4.8, 4.5. I'm going on. Impedance 670, great impedance. I'm running the test. Can we check for 10 volts? Any diaphragmatic pacing? Nothing. At 5, I'm capturing. At 4, I'm capturing. At 3 volts, capturing. 2 volts, capturing. 1. I lost at 1, back to 2. I'm coming down slowly at 1.8, 1.8, 1.7, 1.6, 1.5, 1.4, 1.3, capturing still, 1.2, 1.1, 1, still capturing, 0.9, 0.8, 0. I lost at 0.8, so I'm saving at 1.
Yeah. Perfect.
Okay?
All right. So hopefully everyone found that fun and enlightening. So I will ask, if you work in the industry or if you're a physician, you come across interesting cases to send them our way or to record your own, and we can share these to the World Wide Web on how best to deal with these situations. We don't want them just to be on Avid. We want Medtronic, we want Biotronic, Sorin, across the spectrum. And if you're working in the field and you have specific questions, reach out to us on our WhatsApp groups, on our LinkedIn at the GCCs, LinkedIn Global Cardiovascular Collaborative, LinkedIn, at the CVEF YouTube channel. We're here to help. Let us know how we can better support what you're doing. It's not just going to be EP, but we're working on interventional cardiology as well as other disciplines. So thank you so much for joining me today, and look forward to chatting another time.